Welcome to this educational activity entitled Clinical Profiles in Severe Eosinophilic Asthma. This is a non-promotional, non-CME disease state educational program brought to you by CHEST in collaboration with and sponsored by GlaxoSmithKline. I'm Nick Hanania. I'm Associate Professor of Medicine in Pulmonary Critical Care and Director of the Airway Clinical Research Center and Interim Chief of Pulmonary Critical Care at Bentop Hospital in Houston. And with me, it's my pleasure to introduce my co-moderator, Dr. Linda Rogers, who's Associate Professor of Medicine in Pulmonary Critical Care and Sleep Medicine at Mount Sinai National Jewish Respiratory Institute in New York. Welcome, Linda.
Welcome, Nick. I'm glad to be doing this program with you.
Same here. It's always a pleasure. So our focus today is to talk about, it's a disease state program to talk about eosinophilic asthma and severe eosinophilic asthma. We have three sections in this program, case-based discussions, but initially I would like to start with some few introductory slides. We know asthma continues to be a big problem throughout the world. Uncontrolled asthma is very common, actually not shown in this slide, but accounts for about 50% of patients with asthma out there. This slide really reminds us that there are differences between what we call uncontrolled asthma and severe asthma. Certainly, they can be interchangeable in some situations, but not in all. Out of all uncontrolled asthma, about 5 to 10% of patients have severe asthma. Therefore, how do we define severe asthma? As you see on this slide, it is defined as asthma that remains uncontrolled despite need for high-dose inhaled corticosteroids and another controller, or asthma that requires high-dose inhaled corticosteroid and another controller to prevent it from being uncontrolled asthma. In addition, asthma that requires oral steroid therapy on a long-term basis is also defined as severe asthma. Now, that's obviously in the context of uncontrolled disease when everything else has been checked off, including adherence to therapy, triggers, treatment of comorbidities, use of inhaler devices. As you see on the right side of the screen, uncontrolled asthma continues to be a very important risk factor for exacerbation and progressive decline in lung function. Often, as I mentioned, severe asthmatics can have uncontrolled asthma, but that is not to say that all severe asthma patients cannot be controlled. And indeed, there are several ways we can control these patients. However, among severe patients with asthma, about 20% or so are considered to have uncontrolled disease. So over the years, our thoughts of asthma have changed. In fact, now in the year 2021 and going forward, we are thinking about this whole disease in a different way. For many, many years, we thought this is a disease that has one size that fits all. And indeed, for many years, we approached this disease as a one-phase disease. Now we come to realize, both from the clinical aspect, from the triggers, from even the inflammatory aspect, this asthma is a heterogeneous disease. Indeed, clinically, we see patients with mild disease, moderate disease. We see late onset asthma, early onset asthma. We see allergic triggered asthma. We see late onset non-allergic asthma. And there are certain subtypes, what we call phenotypes, that may affect treatment and management strategies for this disease. More lately, we are now defining asthma based on the mechanism of airway inflammation that occurs in this disease, i.e. what we call endotypes. And as you see on the right side of the slide, we have several endotypes that we have now seen, and that's based on bronchoscopy evidence, sputum testing, other biomarker testing. We know that eosinophilic asthma is a major component of asthma in general, particularly severe asthma. There are neutrophilic asthmatics. There are patients with airway inflammation with asthma that don't have neutrophilia or have mixed type of inflammation. Well, inflammation in asthma is certainly heterogeneous too. For many years, we sort of focused on one type of inflammation, which is a very common type, and that's called T2 high asthma. Or in the past, we used to call it Th2 asthma. Now, as you see on the left side of the screen, Th2 asthma is now recalled as T2 asthma. T2 asthma is driven by either an adaptive immune response, which usually is triggered by allergens handled by the Th2 cells, as you see here, or through innate immune system, where this trigger is usually due to other non-allergic triggers, pollutant, smoke exposure, microbial exposure, or other exposures that trigger the very similar downstream signal, but it's triggered by innate lymphocyte C2 cells and others. And you can see the profile or cytokine profile of this type of asthma is very similar, where it's triggered by what we call T2 cytokines, including the IL-4, IL-5, IL-13, and inflammatory cells, including eosinophils, mast cells, and obviously other cytokines that are seen on the slide. So that's the most common type of asthma we have, type 2 high asthma. On the other hand, we have non-type 2 asthma, as shown on the right side of the screen, that is usually triggered by non-allergic triggers, and inflammatory-wise, it is triggered by inflammatory cells that are not seen in type 2 asthma, most often neutrophils and other cytokines such as IL-17, IL-8, rather than the T2 cytokines. The bottom line, inflammation in asthma is very common. Certainly, it is heterogeneous. The majority of asthmatics have T2 high asthma. Eosinophils play a major role in this type of asthma, which is the focus of today's discussion. Now, how is that related to what I should do in my clinic? When I see an uncontrolled patient with asthma who comes to me, how do I define T2 inflammation? Well, Gina, in their latest reiteration, defined T2 inflammation based on biomarker profile of the patient. High blood eosinophils, more than 150 cells per cubic liter, or high pheno, more than 20 parts per billion, high sputum eosinophils, or asthma that is clinically allergen-driven or allergen-triggered, or the presence of high or need for chronic oral steroids. So this is the type 2 asthma sort of definition based on biomarker profile, and of course, a clinical presentation. So the focus of today's discussion is going to be on eosinophilic asthma, a major subtype of T2 high asthma. Why eosinophils? Because they are very important cells that drive the disease, particularly T2 high inflammation or T2 asthma. We know that eosinophils are brought from the bone marrow to the airway through different mechanisms, particularly through a cytokine called interleukin-5. Interleukin-5 is an important cytokine that signals the recruitment of eosinophils to the airway, but also promotes the maturation of eosinophils and also prevents the death of eosinophils. So therefore, it's a very important cytokine for eosinophilic asthma. As you will hear from me and from Dr. Rogers, we will present to you a few clinical scenarios where severe eosinophilic asthma present to us. And although we're not going to dig deep into the management, I think it is very important to understand the pathophysiologic mechanism, the clinical presentation, so that you, therefore, the next step, take a step to appropriate management. So with that introductory slides, I would like to turn it over to my colleague, Linda Rogers, who is going to really walk us through a case scenario, how to identify severe eosinophilic asthma in the year 2021 and what we have learned. Linda, the floor is yours. Please go ahead.
Great, Nick. Thank you so much for that great introduction. And so let's take some of that great introduction that Dr. Hanania just presented to us and see how we can make that relevant to what you all see in your clinical practices. And so this is our first patient and our first case. This is Olivia, who has severe eosinophilic asthma. And so let's tell you a little bit about Olivia. She is 50 years old. She's 5 feet 6 inches and 174 pounds and has had asthma for quite some time, almost 20 years now, with an adult onset diagnosis at age 30. She has very difficult to treat asthma. She's had 3 exacerbations treated with oral corticosteroids in the past year, and she reports intermittent dyspnea and wheezing on most days. waking at night at least once a week on average, with asthma triggers being upper respiratory infections, strong odors and fumes and exertion. And on her asthma control test, she scored 16 out of 25, which is indicative of uncontrolled asthma. She's being treated with a high-dose inhaled corticosteroid and long-acting beta agonist, and is using her short-acting beta agonist on most days at least twice daily. So you do a little bit of an assessment. You obtain some blood work and allergy testing, and her complete blood count with differential reveals an absolute blood eosinophil count of 420 cells per microliter, which is quite elevated. Her total IgE is a 35, but her allergen skin prick tests are negative, and she has mild obstruction on spirometry. Next slide, please. So what are the characteristics of severe asthma, and what are the characteristics of severe eosinophilic asthma? So, first of all, about 5 to 10% of all asthma patients have severe asthma. And depending on the criteria one uses, up to 84% of patients with severe asthma will have evidence of eosinophilic inflammation. So severe eosinophilic asthma, a subset of severe asthma, is characterized by persistent eosinophilia, driven either, as Dr. Hanania pointed out earlier, by allergic or non-allergic triggers. And the eosinophil cutoffs can be easily obtained using basic blood work available to most providers. And a cutoff of 150 cells per microliter or more corresponds very nicely with a group of patients who are potentially responders to targeted biological therapies, which target type 2 or eosinophilic inflammation. So what are the clinical characteristics of these patients? How do they present in our practice? And so these patients often have significant persistent airflow limitation and a significant number of exacerbations. Although this presentation can present at any age, more commonly these patients have late onset disease, often in adulthood. And it's common for them to have chronic rhinosinusitis with or without nasal polyposis. And so prevalent sinus disease and prominent sinus symptoms often travel hand in hand with their severe asthma. And that includes a subtype of patients with chronic rhinosinusitis and asthma, which are those patients who have aspirin-exacerbated respiratory disease. And there are biomarkers also that are included the presence of this phenotype, and that can include increased sputum eosinophil counts if you are at a center that does sputum induction as part of your evaluation. More commonly, we are looking at this in the blood eosinophil counts, and these patients may have increased exhaled nitric oxide levels as well. And so what are the role of eosinophils in asthma pathogenesis? So eosinophils are commonly recruited to the airways during asthma, and they play an important role in multiple asthma phenotypes. And as alluded to earlier by Dr. Hanania, there is an allergic phenotype where alarmins, which you can see at the top of the slide on the epithelial surface, are produced, and those include IL-25, 33, and something called thymic stromal lymphopoietin. And those orchestrate an adaptive immune response, including Th2 cells, with recruitment of B cells, class switching for production of IgE, which cross-links mast cells and basophils and really results in the early and late allergic response that most of us are familiar with. And eosinophils are part and parcel of the airway inflammation that is generated in allergic asthma, but we also have eosinophils playing a cardinal role in our non-allergic asthma types. And those patients can have disease triggered by the presence of irritants, infections, air pollution, and other non-allergic triggers. Many of the same alarmins are involved in this process as highlighted in the allergic group of patients. However, this pathway goes through the innate immune system with a prominent feature of innate lymphoid cells, but a similar pattern of cytokine production, including IL-4, 5, and 13, which is are the cardinal cytokines involved in the type 2 inflammatory response, and eosinophils are very much in the center of all of this. And so our subtypes you can see here are allergic eosinophilic asthma, non-allergic eosinophilic asthma, and then asthma that is pauci-inflammatory or neutrophilic asthma, which is a type 2 low phenotype. And so eosinophils are also central to many of the features of disease, and they're central to airway hyperresponsiveness. They can be involved in recruitment of release of leukotrienes and histamine, which are involved in airway hyperresponsiveness, production of interleukin-13, which is central to the mucus production in goblet cells, production of proteins such as major basic protein and eosinophil peroxidase, which are involved in epithelial tissue damage, and recruitment of other mediators such as basophils to the airways, and stimulation of the extracellular matrix via TGBF and with airway remodeling. And blood eosinophils are important in terms of risk events related to asthma. So you can see here in this study by Price et al. From the Lancet in 2015 that above the level of 200 cells per microliter, every 100 cell per microliter increase in eosinophil count is linearly associated with increased risk of asthma exacerbation. Moreover, the same levels are increased in increased likelihood of poor asthma control. So there is a linear response between eosinophil count and both risk and asthma control. And that threshold starts above 100 to 150 cells per microliter. In the general population, we see usually a count of 100 cells per microliter or less for context. However, you have to be careful in obtaining and interpreting blood eosinophil counts because there are a number of factors that can affect eosinophil levels, including diurnal variation, seasonality, comorbidities, and concomitant oral corticosteroid use. And so obtaining eosinophil counts while on oral corticosteroids can mask the presence of eosinophilic inflammation. And so it is important to check ideally when patients are not on oral corticosteroids. In one study of biological therapy evaluating the placebo patients in a clinical trial, about 65% of patients on medium to high dose inhaled steroid, corticosteroids, and long-acting beta agonists shifted their eosinophil category over a 12-month period. About 70% of patients who at one measurement had an eosinophil count less than 150 cells per microliter had a count over 150 cells per microliter during a 12-month evaluations, highlighting the variability of this measure. And in patients with severe asthma who continue to exacerbate on standard of care, that threshold of 150 cells per microliter or greater is a marker of airway eosinophilia and potential for eligibility of advanced therapies. So repeated measurements may be possible at least 3 times before assuming a patient is type 2 low rather than having eosinophilic inflammatory profile. So these patients with eosinophilic asthma have a number of outcomes that are worse than many other patients with asthma. They tend to have more severe airflow limitation. They tend to have greater airway hyperresponsiveness, increased airway remodeling, increased goblet cell and mucus hyperplasia, membrane thickening and fibrosis from deposition of extracellular matrix as highlighted in the earlier mechanistic slides, and airway smooth muscle hypertrophy. All of this corresponds with poor symptom control, increased risk of exacerbations, including hospitalizations. And so here are the most recent GINA guidelines for asthma therapy. And I'm not going to focus for the moment on step therapies 1 through 4, as this is not really the focus of this presentation. We're going to really focus on step 5. And you can see here in step 5, once a patient is not achieving control on medium to high dose inhaled corticosteroid and a second controller, which is often but not exclusively a long-acting beta agonist, we are usually adding on additional therapies, and those can include drugs like a long-acting muscarinic. But for patients having more than 2 exacerbations per year and patients with an eosinophilic phenotype, we're often adding on a biological therapy, and that may include anti-IgE monoclonal antibody, anti-IL-5 therapies, which can include both cytokine blockers and receptor antagonists for the anti-IL-5 pathway, and anti-IL-4 receptor alpha therapies for add-on therapy. So what are the next steps for our patient? Getting back to Olivia. So I'd like to highlight some next steps and what I would do in my evaluation of Olivia and some take-home points. So first and foremost, we must always verify that the patient is adhering to appropriate therapy and using correct inhaler technique. We may prescribe therapy, but we want to make sure the patient's actually getting it and getting it with correct technique before we assume that a patient needs a higher level of therapy. We also want to attempt to minimize oral corticosteroid use over time by making sure that they're on maximal ideal inhaled therapy, by modifying triggers and treating comorbidities. And once we've done all of those things, if a patient is not achieving the goals of therapy, we may want to consider escalating therapy if we have evidence of eosinophilic asthma. So to highlight some take-home points from Olivia's case, first of all, the phenotype should be assessed in patients with persistent symptoms and exacerbations despite high-dose ICS/LABA use. Between 74 to 84% of patients with severe asthma may have an eosinophilic phenotype. Biomarkers can sometimes be helpful in assessing patients for eosinophilic asthma, but a single measurement may not be sufficient to diagnose or manage eosinophilic asthma. And in severe asthma, high eosinophil counts correlate with increased severity, poor asthma control, and worse outcomes, including exacerbations. So,
and that was great. Go ahead.
Yes, thank you, Nick. As we go through this and we think about our patient Olivia, it really makes me think about how specialists like us evaluate eosinophilic asthma in our practice. So first, maybe if you can comment a little bit on how you phenotype patients in your practice, and then maybe we can talk about how to do that outside of a severe asthma program, like the programs that we're involved in.
Yeah, thank you for the question, Linda, and for really setting the stage for this discussion. As I mentioned in my introductory slides, we really do we're thinking outside the box now when we approach severe asthma. And certainly it was by demand that we had to think that way because we know not all patients behave similarly. So I look at the clinical presentation. So I certainly like to look at how long has the asthma been? Is it allergic triggered by history? Does the patient have, we'll talk about comorbidities in the next section. I always ask about allergic comorbidities, allergic symptoms. When did it start? Exposures. I have a lot of patients who smoke and they have smoke-related asthma. And certainly, after looking at the lung function, I do look at biomarkers. Now it's a standard of care in my practice. But again, I run a severe asthma clinic to look at biomarkers, particularly blood eosinophils, but I'll also measure total IgE, allergen-specific IgE, and also pheno. In some patients, at least, I'm trying to do more and more measurement of these biomarkers to try to subtype these patients. But I have to admit, numbers, only one-time numbers, as you mentioned, it's very important to keep or have this cognition in our brains that a one-time number may not tell you the whole story. You have to look at the clinical presentation, and occasionally these biomarkers have to be repeated, especially if patients have been on oral steroids that had just come out of the hospital. You cannot just depend on one measurement. In fact, Gina suggests measuring them 3 times. You can go back to the chart and see historically what they have done with previous blood eosinophil counts. And if it's measured, most of the time these patients must have had a CBC with differential done in the previous years. And of course, I look at physiology, at lung function, to decide on whether the patient has airway obstruction, how bad it is, and so on.
Yeah, I mean, that's very similar, which I would expect because we both work in severe asthma programs. We do exhaled nitric oxide, pheno on most of our patients. But I think for people out there in the community who either don't have exhaled nitric oxide testing in their practice, really, 2 of the key things that you just mentioned that we can do in most practices is, blood allergy testing, IgE levels, and a blood eosinophil count optimally off of steroids. And so I think this type of evaluation can be done in most community practices, at least on a preliminary level for most patients.
Yeah, and I think one has to keep in mind that also blood eosinophils can be variable between one day to the other in the same patient. There are some diseases that may mimic or cause high eosinophils. Luckily in the US, we don't have lots of parasitic infections, but in some countries, other causes may be causing the eosinophilia. So one has to always be with eyes open to make sure that the eosinophilia is due to the asthma itself and not something else.
Yeah. Yes, agreed on all counts.
I'm glad we are. I think it's really a game changer in asthma, where we now have biomarkers. More to come. Obviously, the talk about maybe composite biomarkers in the future, that maybe we should look at more than one thing to even divide this pie more and maybe lead to a more precise approach for the disease. I think it's just the beginning right now, and I'm glad we are there, because that really permitted us to hopefully personalize the approach for this disease.
Yes.